And I should be back. There I am. And I would like to take this opportunity now. We'll get Dr. Bevilacqua's camera and microphone on, and we will commence with the next presentation. There he is, Dr. Bevilacqua. How are you?
Great. Good morning, or I guess midday for all of you guys, but good morning out here. Good to see you
Oh,
all.
a very early good morning to you on the West Coast. Thank you for joining us. As we all know, those in attendance, Dr. Bevilacqua out of BC Renal in Vancouver will be discussing pain management and PKD. He'll be discussing the prevalence of pain in PKD patients over the course of the disease, and he'll also explain the different types of pain in PKD, give suggestions about how to describe and monitor PKD pain, and suggest chronic pain management strategies and resources. Dr. Mike Bevilacqua is a nephrologist with additional training in health administration. His clinical nephrology practice is based in Surrey, British Columbia, and he is involved in several administrative roles with BC Renal. On top of that, he is the chair of the Provincial Kidney Care Committee, which coordinates care delivery for over 15,000 British Columbians living with chronic kidney disease. And he is the medical lead for the BC Polycystic Kidney Disease Network, which aims to optimize management of PKD in BC. He is also the co-chair of the Transplant First Committee, aiming to improve access to living donor kidney transplantations. So somehow he still finds time to join us every time I ask him to, which is fantastic. We love having Dr. Bevilacqua present. We were just out together in Vancouver for an in-person forum, which was a marvelously attended event. And he joins us here today, switching gears to talk about pain management and PKD. So thank you, Mike, for joining us. We're going to throw to your presentation, and then, of course, we will be joined for the live Q&A in approximately 45 minutes.
Sounds great. Thanks for having me.
Hi, everyone. Glad you could be joining us in this 2023 PKD Summit. I'm Dr. Mike Bevilacqua, coming from British Columbia, and today I'm going to be talking about different types of pain and how we manage pain in people living with polycystic kidney disease. Before we get started, just a few disclosures, which are listed here. One pertinent one is related to the manufacturer of tolvaptan, which is used for polycystic kidney disease. To mitigate this, I'll only be discussing published data or existing guidelines for usage of this drug. Okay, but to get into the content for today, there's a whole range of items we can discuss related to pain and polycystic kidney disease, and I'm going to take you through each of these in turn. We'll talk about pain in general and how common it is in people living with polycystic kidney disease. And then after that, though, we're going to spend a fair amount of time discussing a way to categorize and describe pain a little bit better. Because as you'll see, and as many of you are aware, there are different types of pain that you can encounter, and we'll go through that in some detail today. We'll also then discuss some management strategies that we have for these different types of pain, as well as some helpful resources that you can go look at now or later on as they're needed as well. As a reminder, and many of you would have seen some of this information before, but just to start from the beginning, when we're talking about polycystic kidney disease, and today specifically autosomal dominant polycystic kidney disease, this is a common inherited genetic condition with the numbers listed there on the order of 1 in 400 to 1 in 1,000 people. Now, framing this specifically for our conversation around pain, what happens with the polycystic kidney compared to the regular kidney is that it starts developing these cysts. These little bubbles you see here on the one on the right, those are meant to represent the cysts as compared to that pinkish brownish stuff in the middle that's the healthy kidney tissue. So as time goes on, people with polycystic kidney disease tend to develop more of these cysts. The cysts get bigger, and they can actually start to change the architecture, change the composition of the kidney. To the point that the kidney both gets distorted, but actually gets quite big as well. The comparison we have there is that a normal healthy kidney is about the size of a fist, whereas in patients with polycystic disease, the kidneys can become many times that large, 5, 6, 7 times larger, sometimes even more. And this is where we start to see some of the painful complications that can arise from it, is from this change and distortion of the architecture. The kidneys themselves, as they get big, that can cause some problems. And those cysts themselves, as they get big, things can happen to them. They can start to have issues with things like infections, stones can develop in them, or they can even rupture or pop, if you want to think of it as that way. And this is kind of listed here. Again, this figure might be quite familiar to many of you out there in terms of all of the different items that can come up with polycystic kidney disease being a whole body issue, not just a kidney issue. It can present with these different items around the body. But the ones that I have in boxes here in red are the items that can be giving different types of pain. As I just mentioned when we talked about that kidney architecture, the cysts can rupture, which can cause pain or bleeding. They can get infected. You can get some stones. You get symptoms just from how big the kidneys are themselves. But it is worth mentioning these things on the right-hand side as well, meaning that even outside of the kidneys, there are other reasons that people might have pain in their abdomen that can go along with polycystic kidney disease. We talk a lot about the kidney cysts, but the liver cysts can have those same complications. Those can rupture, those can get infected. So the same type of thing can occur, causing some painful complications. There can be issues with hernias. Hernias are a thing that we see in the general population as well. And what a hernia is where you have a weak point in your abdominal muscle wall and things can kind of bulge through, if you want to think of it that way. And again, that can happen in the general population. One of the risk factors for it is an increase in pressure in your abdomen. And when your organs, both your kidneys or your liver, are quite big, it's one of those items that can cause that increased pressure. So people with polycystic disease are at a higher chance of having a hernia. And there's this item called diverticulosis, which again happens in the general population. These are out pouches or out pockets of your intestinal wall. It is one of the known complications of polycystic kidney disease. Now, in and of themselves, they don't tend to cause a lot of pain, but these items can actually become infected or inflamed, something we call diverticulitis, which can be quite a painful thing as well. And so I wanted to mention those ones to say that although we talk a lot about the kidneys, there are other abdominal reasons that people can have painful complications that are related to polycystic kidney disease. Those are a few of the different types of painful items that we see. But in terms of frequency, I like to share this data because it often is a bit surprising to people who are unfamiliar with it. For those of you living with the condition, you would know this, but for healthcare providers, often what they might see, especially early in the disease, is somebody who looks young and healthy and otherwise doing well. And they're sometimes surprised to hear just how common it is that those patients, even early on, are having these painful episodes. So what this little figure here is showing us is as time goes on, so we have age here at the bottom, we see how many people are having these different types of complication. So when it starts at 100, it means nobody's had them yet. But then as the line goes down, it means more people are having those complications. And when you start to look across, you see a few points come out. This figure is telling us that in general, by age 30, about 50% of people have had one of these complications. Now, the most common of that is hypertension, which is kind of seen even very early in people with polycystic kidney disease or high blood pressure. But some of these other ones are the painful episodes that we're talking about, things that cause gross hematuria. That means blood in the urine, often can be related to a cyst rupture, which can be painful, an infection, or this term nephrolithiasis, that means kidney stones. So these are painful complications. And you can see, for example, for things like infections and blood in the urine, by the time people are about 40, about half of the people have had one of these. So again, this is quite common. And in fact, so common that in up to a quarter of people with polycystic kidney disease, the first thing that happens that leads to their diagnosis is some kind of complication. One of these items comes up, then we look back and find the polycystic kidneys. So this is all to say that very early on, it's quite common for people to have a lot of these complications come up. It tends to be something that people think of as being a later item, but it can happen early in the disease as well. And to put it a different way, we can look at people just specifically broken down by where their kidney function is. So these little figures that we're talking about, they show different types of complications. So this is abdominal fullness that's interfering with someone's life, decrease intake, so not being able to eat as much because you feel so full, poor appetite, or a noticeable increase in the abdomen. And each of these bars here is broken down by kidney function. And if we look at just those over 60, meaning what would be recognized as quite intact kidney function, we can see that there's still quite a fair amount of symptoms. Even at that really early stage, more than a quarter of people will have one of these types of symptoms. Again, this is all just painting a picture of saying that this can happen even early in the disease, that we can have a lot of these complications. It can start early, but it does tend to progress as time goes on. This figure might be familiar to some of you, and you may even see it some other time today. It's a really commonly used one to show the progression of polycystic kidneys, where you see we're starting with a kidney that's fairly normal in size, that has a few cysts in it. As time goes on, you get more cysts, the cysts get bigger, and you actually get changes. The kidney itself enlarges. And we've seen this a few times to talk about the progression of the disease, but coming back to these painful items, I just want to really highlight again the fact that you really start to see changes in the shape, the physical structure of the kidneys, the size itself can cause some of these symptoms, which we'll talk about in a moment, but also these changes in the cyst are what lead you to some of these other complications. The part of this figure I really don't like is the age, because this does happen at different rates for different people. So we can kind of ignore that just to mean look at that as time going on. But coming down to the bottom part of this figure, you can see that we start to see more of these complications come up as time goes on. So although I was saying on those last few slides, it can start early in the disease, we do see that on the whole, they become more common as time goes on. Now, I say on the whole because it's quite individual and quite variable. Some people will have no symptoms until very late on in the disease. Some people have a whole lot of symptoms and a whole lot of complications early on, and literally everything in between. But in general, as the condition progresses, we do start to see these painful complications becoming more common. Now, I was talking about the architecture changing with the kidneys. I want to go into a little bit more detail, and this is getting even a little bit more technical, but it's relevant because it will play into what we see for different pain types and also how we manage them. So we showed in that figure that kidneys getting bigger and having more cysts, but there are kind of two general patterns we might see. Now, these are big generalizations, and I'm using these as kind of extreme examples because we do see literally everything in between the two of these. But the two patterns we can sometimes think of is on the left-hand side, we can have people who have big kidneys, but it comes from a handful of really large cysts. So if you can see my cursor here, I'm drawing around, that's one big cyst. That's another big cyst. So a smaller number of really big ones. Or we can have the more bubble wrap, or sometimes people call it the Swiss cheese type picture, where it's lots and lots of little cysts. And then again, we can see literally everything in between, but I just like to point these out because both what can happen and how we manage sometimes the really big cysts compared to a lot of little cysts can be different. So when I talk about that change in architecture, it is different for different people. And this is one of the values of your kidney doctor having your own imaging test, so we know exactly which one we're talking about with you. Okay, so that's all a lot of background about the condition, how the cysts grow and change. Now we're going to start getting into the actual pain episodes. So what I'm going to do is I'm going to take you through a few different situations. So these are cases, these are actual images from patients of mine, and we'll talk about a few different types of pain. And then we'll come back to how we can classify this and look into it a little bit more detail. So this is something that may be common to some of you. This is one of my patients. He's a younger gentleman, less than 40 years old, but he's got pretty rapidly changing kidneys, as we can see by the fact that his kidneys are quite big, even by the time he was about 34, and his kidney function's already going down. Because he's progressing, he's one of my patients who's treated with the treatment called tolvaptan, which is a vasopressin antagonist. So he'd been going along, he's been in our clinic for some time, and then called the clinic one day where out of nowhere, just bang, like a light switch, had very, very sudden pain, had some red or visible blood coming through in the urine, and obviously, was quite worried about this. So he called the clinic. When we talked to him, actually, he had a similar episode some years ago in his early 30s, but it's been quite a while since. Okay, so that's one type of painful episode that we had. I'll take you through all of these, then we're going to classify them in a second here. But this is another one. So now we're looking at a different type of person altogether. So this is an older gentleman. He's 80 years old now and still has quite good kidney function. So what we would call someone who's more slowly progressing in terms of his kidney function, but he has had a lot of problems with pain. And actually over the course of his life, probably about 6 or 7 times, he's had what we call cyst aspirations or drainages, where someone goes in with a needle and actually drains out one of those cysts. He's had that a few times over his life. And he has a lot of what we call mass symptoms. That's that fullness, not being able to eat as much. And one of the big items he always talks about is low back pain. I like to point this out here because we often talk about pain for different reasons, right? Some people with polycystic kidneys might go see their family doctor, talk about low back pain, and someone will say, oh, well, that's unrelated to your kidneys, that's just your back. And I always kind of say yes and no. I use this as an example. So this little cartoon in the middle is showing what we call the normal curvature of your spine. Your spine isn't straight. It's meant to have these multiple different curves in it. And sometimes what can happen if the kidneys are quite big, it can actually kind of shift everything and distort that. Now, you kind of have to take my word for it looking at this scan of the spine. There are some arthritis type changes, what we call some wear and tear type changes, which we see in someone who's 80 years old. But we can see that the alignment, you can almost imagine this does look more like a straight line than that nice curved cartoon we see on the side. And this is all to say that you can actually get changes in the composition and the alignment of the back that can cause pain as well. And this is something that's one of his big issues. Okay, and then the last example I'll give is someone who's kind of in the middle in terms of age. So this person's 69. Her kidney function's not normal, but at this age, not too bad, somewhere in the 38 to 40 range on average. But she has the combination of really big kidneys, and you can see from the scan here, these are giant kidneys, lots of little cysts, more like that Swiss cheese model. So big kidneys, but she's a really small person as well. And this can be a rough combination. She's only, just over 1.5 meters and 46 kilograms. So that combination of really big kidneys and a really small person can lead to a lot of symptoms. She hasn't been having a lot of issues with sudden pain, but has long-standing trouble with fullness. I mentioned shortness of breath because she actually feels to the point where she can't expand her lungs properly. When she lies down, she feels quite short of breath. And now more recently has started losing weight because she just can't keep her intake up. So I painted those pictures of 3 different types of patients just to get at the point that we're seeing different types of pain. You can tell the way I described those. Those were not the same thing. Those were all different situations. And we're very lucky that actually just this last year, there's this great publication that came out that kind of helps get at this question of how do we classify the different types of pain in polycystic kidneys, because we might treat those a bit differently. So and I like to point out that this has been a theme here. This is really a patient-driven research item. So they had patients involved in planning this out, asking this question of how do we get to the bottom of pain. And I love this theme that's happening. This is in one of our big journals called CJ's, one of the biggest nephrology journals out there, where when they published this tool, at the same time, they published a patient perspective written by a patient quite interested in this area, so we can see how it affects both sides of the coin. And I love this trend that the literature is going, where the patients are driving these important questions we're asking. Okay, but to get into the actual publication themselves, what they did is they recruited people with polycystic disease, adults, so over 18 years old, and they went to everywhere. I'll show this in a second, but they looked to see what was out there in terms of existing tools to classify pain. And then they really spent a lot of time with these participants coming up with what are the types of pain, what are the symptoms that are important to them, how is it affecting them. They detailed it in about every way you can think of, and then at the end of it, they come up with this really good tool. I'm just pointing this out. We don't need to get into all the details here. This is to say this was a really big undertaking. You can see they used over 100 articles to get at this. They had over 25 clinicians, huge number of focus groups to really get at this. So they really, really did an exhaustive search to come up with this tool. And ultimately, they came up with this, what they call the AD-PKD PDS. And this is really the pain and discomfort scale. And this is a 20 item, so a really usable, manageable checklist that we can kind of go through to classify the pain. Okay, so I had this to say, as I just mentioned on the last slide, that this was a very, very robust piece of work. They really left no stone unturned. I won't go through all of this here, but they went through several phases where they basically developed a tool and then validated it to make sure that it wasn't just one group of people that responded to this, but actually that it was usable over and over again, and ultimately came up with this scale. So I'm going to take you through a few of the results, and then I'll show you the scale in a moment here. But a few of the results, this is really just getting at how common some of these symptoms are. Okay, so just to take you through, to orient you to the figures here, it tells you what topic we're saying. So overall pain, dull pain, sharp pain, discomfort. We'll come to that in a second as to how they classify those better. So they talk about the severity of the pain at the top, and then they talk about this component called interference. How much is it interfering with your life? These different bars, these Gs, that represents the GFR, a categorization of the chronic kidney disease. So the 1s are people with quite preserved kidney function. The 5s are people with more advanced, lower kidney function, and then everything in between. And unsurprisingly, just to orient you, again, we don't need to take you through every single piece of data here, but unsurprisingly, as people's disease progressed, these symptoms both became more common, they became more severe, and they interfered with people's lives more. So not surprising that as disease goes on, the symptom burden is higher. The one part that was a little bit surprising, and the authors talk about this for some time, is this is now looking at health, what we call health-related quality of life. So a higher score means a higher quality of life. And we can see that as people's kidney function goes down, the components of that related to their physical health go down. So same as we just saw on the last slide, that those symptoms become more common. But interestingly, when we talk about their mental health component, that got better as time went on, or as the disease progressed more. So this was a little bit of an opposite finding. But what the authors attribute this to, and speaking with their participants, and I think they're probably onto something, is saying that, as people have been managing this more, even though their physical symptoms have become more common, they're either more adapted to it, or probably the better term is they're able to cope with these symptoms a little bit more. And in other words, they're able to carry on and live despite these. And I think there's probably some truth to that with learning some of these strategies. Okay, so this kind of goes back to our point. It just confirms what we already were talking about, that these pain symptoms are more common as time goes on. But now this is what I really wanted to get to with this classification. And I love the way that they talk about this, where they say we have this big world of pain or discomfort related to PKD, but we can now split this into different pain types. And this kind of goes back to those 3 cases I was telling you about, where we have kind of this dull, chronic, or long-term pain. We have sharp or sudden kidney pain. And then the third one is not pain specifically, because it's not a painful item, but that feeling of fullness, or just discomfort, or kind of uneasy, but not painful. And this really does echo what my patients have been telling me for years when they talk about these different pains. And it's really nice to see it classified in this way. So we have the different pain types, and then they talk about these 2 domains. For each type of pain, they talk about the severity and the interference. And I talked about this a little bit of the last slide, but just again, to get to the difference between the 2, the severity is how bad is that pain or discomfort. The interference, which is just as important, or in some cases maybe even more important, is how is it impacting your day-to-day life? So you can see when we're talking about things like this dull pain, it talks about your daily activities, your leisure activities, sleep. That's a really big one. If you're uncomfortable to the point that you can't sleep, right? Life enjoyment. So for the chronic pain, we're talking about that. For the sharp pain, that since that tends to be a more short-term item, it's really getting to how often is it happening? How bad is it when it's happening? Do you have to stay home from work? That type of thing. And then lastly, when we get to this fullness one, same type of thing, right? So we talk about severity, but then the interference, you can see we're talking about interfered with different activities, eating being a big one, bending and stretching. That might seem funny, but that's actually one of the big questions I ask my patients is it to the point where you're having trouble bending over to tie your shoes or something like that? Because that can really tell you just how much it's impacting somebody's mobility. And so I love the way that they broke this down, where specific to each type of pain, it gets at what are the interference related to it. so that we can kind of now rate each of them in a very descriptive way. So I love that this is doing this. And it's helpful not just to understand the pain, but it does point us in different directions in terms of the management, which is kind of what we're going to start getting into now. So this is my general approach to it. I think you might see other people do the same type of thing. And so if we talk about these different pain types, we actually manage them, we treat them differently. I'm actually going to start in the middle, because that I think is the more straightforward one. It's funny to say that the severe sharp pain is the more straightforward one, but it's more straightforward because that's something we're kind of more used to, in medicine, meaning it's a sudden item, it's not a long-term thing, bad pain. It's really about how do we manage it and when do you need to go see a doctor right away. That's really what that one's getting at. But these other two are a little bit trickier, right? When we're talking about this dull kidney pain, we're really going to be getting into what we call chronic pain management strategies. It's not a one-day episode that we just have to see you through until you kind of get to the other side of it. This is a long-term item, so the management's a bit different there. And then when we talk about the fullness, again, we'll talk about some of those same long-term pain management strategies. But here now we're actually, there's a group where we might consider actually some interventions for what we call the mass effect. And the mass just meaning size, meaning, so here what that phrase means is some interventions where we might actually try to target the kidney size that is causing those symptoms to see if we can reduce it and improve the symptoms related to it. Okay, so it kind of ties in nicely that the way we categorize the pain also helps us with an approach to how we're going to manage it. So as we go through each of these, I just want to point back to the resources that actually I'm going to be calling out. We're so happy and so fortunate to have this, that we've got this great resource around pain and polycystic kidney disease that we were able to all develop together. So I've shown on both websites, both the PKD Foundation of Canada website, as well as our BC Renal website. It's the exact same resource on both websites because we made it together. It's so great to be able to partner with the PKD Foundation. We also had some participants from the Kidney Foundation involved. And together, between those different groups and a whole bunch of patient participants as well, we were able to come up with these pain resources that I'm going to point to in a second. But I wanted to specifically call this out because after this talk, if you want to go pull it up, if you go to either of those two websites, you'll find these resources in full. Okay, but now let's come back to those three people that I talked about, those three cases, look at them in the lens of this classification, and then see how it is that we're going to manage them. So to remind you, our first gentleman, this was the young patient that I had who's quite aggressively progressing disease, quite rapidly progressing disease, and he had that sudden bang out of nowhere, sharp pain and blood coming through in his urine. So this falls into that one of what we call sharp kidney pain, that one right in the middle there. And I have the picture here. These ones highlighted in the box are the ones that are the big offenders when we think about the kidney-related causes. And especially when you hear of that story of pain out of nowhere and blood, and I'm immediately thinking, okay, it's either a cyst rupture or a stone. Sounds a little bit more like a rupture, but probably one of those two. So when we're talking about cyst ruptures, this is a really common complication, especially as time goes on. And I always tell my patients, it can present with any one of these things. So some people get the similar symptoms over and over again, but it can be any combination of them, meaning some people get pain, some people get blood they see come through in their urine. You can get both, you can get neither. There are some silent cyst ruptures and everything in between. And what a lot of it has to do with is exactly what type of cyst and where it's sitting. As a general rule, when we think about those pictures, the ones on the outside tend to be painful, the one on the inside tend to bleed, and then some combination thereof. But it really can be any combination of these items. So it's all to say that just because it's happened a similar way a few times doesn't mean every single cyst rupture is going to be the same. It might be different either for the same person. Now, again, as I said here, it's really about bridging somebody through. So some of the general strategies that we tell people to work at if they're trying to ride this out at home is, drink lots of water, do some of your pain management items there. But then the real question here around this one is, when do you need to go see a doctor right away? And we put these items here, and I think it's worth going through. If you can't control the pain at home, obviously that's a reason you need to go in. If the bleeding is either not going away, I tell my patients as a general rule of thumb, if it's not clearing within 24 to 36 hours, or if there's lots of blood, clots coming through, things like that. If it's actually getting worse as time goes on instead of better, or if you're starting to feel generally unwell, like lightheaded or dizzy, these could be symptoms from blood loss. You need to go in right away. The other reason you need to go in if you're having one of these items is that just because we talk about these things related to polycystic kidney disease, people with polycystic kidney disease can have other reasons for pain, right? You can have an appendicitis, you can have something else going on in your abdomen, and they'll be able to check you out and see what's going on there. Okay, so as I said, that one's a little bit more straightforward, actually. I think these other ones are trickier to manage when we're getting into the chronic pain. So now we're coming back to our gentleman here who's had both what we call MAS symptoms, so fullness, but just this chronic discomfort and back pain and longer term, not as sharp pain, but longer term pain. So now we're getting into this box of that dull kidney pain. And the real management strategy here is what we call our chronic pain management strategies. And I think this can often be really the most challenging category because unlike that sudden item where you really just have to get through the immediate period, this is going to be around for a long time. And so it's really about working with the pain and trying to eliminate it. And that's kind of the foundation of chronic pain management, is that our goal isn't to eliminate the pain, meaning it can't make it zero. It's really how can we learn to lessen the pain? And I think the real, tying it back to that classification, it's really about how do we work with the severity of pain, and I think the interference. And probably the second point is the biggest one, meaning how do you still live your life in a way that you can still do the things you want to do with this pain being there. And I like to say this that way because it's a realistic thing. I mean, all of us would love to make the pain disappear, but in some of these situations we can't. So it's really about how do we still have someone have an enjoyable life despite this. So when we get into chronic pain, this is an area where actually, and these figures are from our resource here. I'm not going to read this all out here, but this is where these what we call self-management strategies are really the first choice. And that's because they're actually often the most helpful. And just to go through a few things, you can see that it talks about some ways you can get physical relief, things like finding a good positioning. I have patients who have all kinds of wedge-shaped pillows and things like that they can help kind of get in the right position when this happens. Use things like heating pads, stuff like that to kind of minimize the severity at the time. And then work with some exercise and gentle stretching to kind of make sure that they're able to keep that mobility up. This is a big one. I come back to that gentleman who's having the back pain. Again, he's having this back pain, part of it because the spine architecture has been changed so much. So continuing to work with these items like some gentle stretching and things like that actually can help make sure you preserve that mobility. So again, I'd like everyone to read through that resource, but this is where these self-management strategies are so helpful. And then we get into other items that we bring other people into. So we start with self-management. It's kind of nice because it's kind of what can you do to take control of the pain at home. Then we start to bring some other people in there, things like physiotherapy and massage. I've definitely had patients who have had benefit from things like acupuncture and things like that. This one's highlighted here because there's a link to it, but I love that it's highlighted anyways. Things like meditation and specifically, mindfulness types approaches in different forums have been found, have been proven to be quite effective in chronic pain. And the same is true when it's related to the cystic kidneys. And then you could see things like, distractions and trying to find something else to do to minimize the impact. As we get more and more into it, these ones on the right-hand side is where you might have someone like a psychologist or a counselor involved, but they really come to the same thing of strategies to learn to live with this, that being the primary goal rather than resolution of the pain. And that's really the key message here. And we have all these different options here because often it's some combination of them that works for people. It's not any one magic fix for anybody, for all people. It's whatever works for the individual. We have listed last medications in that resource, and that's because it really is in the order. And it's not that we don't want to give people medications, is that since this is a long-term item, especially since some of these pain medications can come with issues, especially if we're getting to the stronger stuff, which we actually try to avoid in these types of chronic pain. We do try that people have tried these other strategies first. There are situations, though, of course, where this is going to be a needed thing. And so we have some considerations around using this medication. Again, I'm not going to read this all out for you here, but I just wanted to put that point of this being kind of a stepwise approach. We have listed here, some people have, and this question comes up a lot, so I like to address it head on, that some people have tried cannabis for management of this pain, and there can be some benefit there. I do like to remind people, though, if this is something you're thinking about, there are kind of, considerations to make sure you're doing this in a safe and productive way. And actually, the PKD Foundation I hosted a webinar earlier this year, myself, along with some pharmacists and a patient partner, where we took people through considerations if this is something you want to try. So go ahead and check that out. That's on the website if it's something that you're interested in. I like to post it because that question comes up quite often. Okay, and then so the last part of this chronic pain management strategy, because there's so many different components to it, is this option of a pain diary. And I think this is actually just super, super important when we're talking about these chronic pain management strategies. There's a couple of things to think about here. So this is the one that we developed, that same working group, and it's available on our website. This was before we had that publication, so it's a little bit different. Ultimately, it might be replaced by something like that. But I think whichever tool you use to classify the pain, the concept is pretty much the same, where basically you have a rating scale to talk about the pain at the time. But I think this part at the bottom is actually the most important. So in addition to talking about the pain impact, the pain severity and impact, you try to describe it. See if you can think of anything that caused the pain. What did you try to treat the pain? What worked and what didn't work? And that might all seem like basic stuff, but it's important to think it through and kind of journal it at the time, because the next time around when you're having pain, as those of you who experienced it, when you're in pain, it's not an easy time to come up with solutions. So it's nice to have a very clear description here saying, oh, I remember this type of pain. It's similar to what I'm having today. When this happened last month, this is the strategy I used and it helped or it didn't help. And that way you can kind of learn from your experience. And as people go on and do this more and more, they do find that it really helps guide them to say, okay, for pain type X, this is going to be my strategy. For different pain type Y, this is going to be my strategy. So I do encourage all of you to think about this journaling specifically with this in mind. When it came, what helped, what didn't help, and how do I go and learn for that in the future? Okay, and then so coming back to our patient here, so he's been working with some of these, specifically some things like stretching and to try to keep that mobility, and that helps. I point out that this fullness episode, and I'll come to this in a second too, he did have these cyst aspirations. Remember I said that about in the beginning, he had these drainages of some of these bigger cysts. And kind of as expected, it helps with those fullness symptoms, but it didn't really make that much of an impact on that pain that he's having, which is why those chronic pain strategies are helpful. And that you can see that classification actually we might have predicted that the drainage will help with the fullness, but not with that chronic pain that he was necessarily having. And so I want to get into this last one a little bit more, this one about fullness. And so this was that third individual I talked about, the smaller, shorter person, right? So 1.5 meters tall, 46 kilos, but really, really big kidneys. The phrase I often use with some of my patients is there's only so much real estate that you have in your abdomen. If you're a smaller person, you've got less real estate to work with. And so those same big kidneys in maybe someone who's 2 meters tall, they might not have as many of these symptoms, but this is the hardest combination of small person with really big kidneys. And she's having a lot of symptoms related to that. Her symptoms are all related to fullness, and it is a bit different than that chronic pain, which is why I put it this way. So although it's different in terms of management, we still start with a lot of those same strategies, right? Which are really about how to work with this, because this being a longer term item. So I won't go over it again. We start with those same strategies. But if they don't work, this is where we sometimes think about some what we call interventions to actually decrease the size, decrease the burden of cysts to see if that helps with symptom relief. And we have a combination of things. We have medications, we have what we call radiology approaches, I'll show you in a second, or there can be surgical approaches. If we're talking about these interventions, so this is a picture of a scan here on the left-hand side, and you can see this was that example of one really, really big cyst. that they basically go in and do what we call an aspiration. There's a few different methods of doing that. I won't get into the technology, something called sclerotherapy versus a simple aspiration, but the concept is the same, where you actually drain the fluid out. And this one shows that with just basically eliminating that one cyst, they brought that volume down by 30%. And that's the type of thing that can give a lot of symptom relief. That specific approach where you have one or maybe a handful of cysts making up a really big portion of the volume, they can do well with a drainage. The step beyond that is we have surgical approaches to it. And that's really for more severe cases. Because of the fact that it's a more invasive thing, right? It's a bigger procedure to put somebody through. There are a lot of complications. We also have to think about loss of function. For example, if you end up having to cut out large parts of somebody's kidney, then we're going to lose some kidney function as you do that, right? So there's a whole lot of other things. So that's really reserved for the more severe cases, something definitely to be talking about with your kidney doctor. We have medications as well. So I like to put the drainage because that's often the first thing that people think of. But there are some medications that we can use that can help with these symptoms. The vasopressin antagonist tolvaptan, although we use it mainly for progression of the kidney disease, loss of kidney function, even in the original trial, they did find that there was lesser pain in people taking this medication. And that's because as this medication helps inhibit the cyst growth, and actually it does shrink a little bit the kidneys when you start it, you might get some symptom relief. Now, I like to point out that this by itself is not really a general reason to use the medication, but it is something we think about in more extreme cases. Down here, this is our application form we use in BC, and we do see that pain is there, but you kind of need it in combination with something else. I do like to point out, although this is a bit of a side, I'm not going to put much there. We do have that treatment that we use for the kidneys. There is a similar thing we can do with liver mass symptoms. So this scan, this is another one of my patients. This is a different patient. You can see the whole upper half of his abdomen is just taken up by liver, gigantic liver, as well as a big kidney. And there are some medications we use, something called somatostatin analogs. Again, I'm not going to get into the detail here, but it's a similar concept to the kidneys where they can decrease or shrink the size of the liver. And when they've studied this, that has actually resulted in improvements in things like pain. But it comes with a bunch of side effects. Similar actually to tolvaptan has some side effects. This one also has some side effects, even a higher rate of side effects than that. So it's really an option in just very selected patients. I'm just going over to this to mention there is a different medical treatment for specifically people with really large livers, but it's kind of a more specialized and selected patient group that it's going to apply to. So going back to this case, this was my patient. So actually, this has been one of the trickier ones that I've had with these really, really big kidneys. And I've had her assessed by one of our expert urologists, so an interventionalist, a surgeon, to see if there's anything that he could do, anything we do radiology-wise. And the answer is not really, because she has that unfortunate composition of many, many, many little cysts, which is actually the hardest one to do something about. We've got her essentially on compassionate basis, a trial of that tolvaptan medication, and she did get some relief with that. I think a lot of her improvement has been, again, from some of those chronic pain strategies of just, she's been working with some gentle yoga and stretching and just really trying to keep that mobility up and decrease the impact on her life. So I use those three cases to take us back to this classification, and I really want to highlight this again. And I think an important one is, if you're deciding to go on and do things like pain journaling, remembering this classification will really help you describe that pain. Are we talking sharp pain? Are we talking dull pain? Or not quite pain itself, but that fullness and discomfort? So the approach is relevant. And then we talked about the different management strategies we have for those different pain types. So to put this all together, it's not just an exercise in going through these published papers. I think this is a practical paper, and that's why I'm so happy that it just came out this last year, where you can learn to classify those different types of pain because they often represent different causes of the pain. You might have some of them, you might have none of them. They might come up at different times. And so equipping yourself with that strategy to work your way through it, I think is going to be very, very helpful. I think learning how to manage and live with these is going to be a skill that serves you, as time goes on. I do like to highlight, as always, when in doubt, talk to somebody, and I have it very specifically there for those acute or sudden pains. Knowing when to seek help is absolutely critical. And then we spent a lot of time talking about those chronic pain management strategies because that is going to be the foundation of a lot of the symptom management. Again, the goal is not that there'll be zero pain, but minimize it and get to a point where the impact on your life is decreased. And that's a very, very good goal. And then there are some approaches that we take in more severe cases, but that's something you'll discuss with your kidney team. And so with that, that was a whirlwind tour of pain and pain management in polycystic kidney disease. Thanks everyone for listening. And now we've got some time here for some questions and discussion.
And we're back. So first off, apologies for those slight technical difficulties throughout Dr. Bevilacqua's presentation. The team at Live Agency is working to resolve that to ensure that they don't persist throughout the day. We will welcome Dr. Bevilacqua back on camera and microphone to go through the live Q&A when he's ready.
There we go. Okay, perfect.
There you are.
I couldn't start it. Okay.
That's okay. Great presentation, Dr. Bevilacqua. Thank you so much for going into detail and highlighting, of course, the resources that are out there. In particular, of course, the collaborative resources from BCR, our organization, and the Kidney Foundation of Canada. We'll dive right in out of respect for the time. The very first question, if I may ask, many patients come to the foundation and speak to the fact their primary caregiver, their nephrologist, their GP doesn't necessarily understand or correlate a PKD diagnosis with pain. So there are patients who are coming to us saying, my neph doesn't get it, or my GP doesn't get it. They say that I shouldn't be experiencing this level of pain, or what I'm experiencing isn't PKD related. How can you address that from a patient standpoint when they're being told that their PKD diagnosis or CKD diagnosis isn't correlated to the pain they're experiencing?
Yeah, this is always a really tough one, and I definitely see this with my patients. One of the bigger examples, aside from just their GP and nephrologist, which sometimes can be better because they know them well, if somebody goes to emergency, for example. I think one of the problems that feeds into that is, in a lot of cases, this is an otherwise, healthy looking person, right? So a lot of the times it's a younger person, their blood work shows maybe their kidney function's not that bad. And so not the type everyone says, oh, well, this doesn't look like someone who's having severe pain. But as you all know, and that's why I really wanted to show on the slides, that symptom burden can be very high even earlier on. So it is one of those hidden types of things. And I think that's a big part of this, is it flies under the radar. That combined with it being a more, I don't want to say too specialized, but a not as common reason for it could be why this happens. I always say that you do have to kind of be your own advocate for this. I know the trouble people run into, though, with this one specifically is people will say, oh, they're just looking for medications, or they're just kind of playing up pain. I think trying to describe it as best as possible helps. These strategies that we talked about for classifying and describing the pain, I think that goes a long way too, because it shows that you kind of know what you're talking about here. You're not just saying, oh, I have pain all the time, you need to do something about it, which can be a difficult thing for a physician to work with. So I think going in there equipped with that helps. And, one of the tools that I like to do with my patients, if this comes up and, I maybe ask nicely, it's always hard on the other end of the table to ask for it. But so that's why I was showing those images with the description of the pain, because putting the two of them together really paints a picture, right? And even for someone who might not be as familiar with it, if you go and say you have this pain and they pulled up your scan and see these big cysts in your kidneys, that hopefully brings it home a little bit more that, yes, this is a very real thing that we're talking about. It's an ongoing challenge, though, to be honest. And this is where I think, trying to advocate for yourself is an important thing for sure.
No, and that was a great point to again, refer back to the pain log that's available on our respective websites, because then you're going in and again, you're not just saying I've got pain morning, noon, and night everywhere. You're able to identify the time, the activities you were doing before or after, what helped, what didn't help, time of day, and you go in there again, being your own best advocate, which we'll again learn more about later today. On the importance of providing as much detail as possible. So I think that's great. We'll move on to the next question then. I understand that this is from an anonymous attendee, I should mention. I understand that everyone has different issues but will family members' symptoms predict, say, how their child's journey with PKD? So pain, cyst growth size, kidney abnormalities, so on and so forth.
Yeah, that's a really good question. The short answer is basically no. And what I mean by that is it's very individual how people do with the disease. So even though in a family you all share the same gene that causes the PKD itself, there's so many other factors that feed into it that we see all kinds of variability in how people do with their kidney function, so not just these symptoms, but how long their kidney function lasts, definitely what happens with symptoms. And so that's why I always say each individual needs their own specialized assessment by a nephrologist, because the courses, even in a family, can be so very different from person to person.
Absolutely. Thank you for that. Another question from an anonymous attendee. At age 50 with GFR 30, I'm experiencing cognitive changes. I don't know if this is PKD related or just age. So this is a bit off from the pain and PKD aspect, but they're curious to know about the PKD effects on brain function.
Yeah, that's always hard to say at that level. I wouldn't expect a lot from the kidney function itself, but it's hard to say between that and of course, medications and things of that nature. So I would say bring it up with your physician just to go through. I used the example earlier when we were talking about the pain of, oh, well, people with PKD can also have appendicitis. This is a similar thing here. It's always, although it's tempting sometimes to say, well, this is related to the one condition we know is going on, it's always worth taking a step back with your doctor to say, well, maybe there's something separate. In other words, you don't want to miss something. You want to make sure that you still have that proper assessment. So yeah, bring that back and talk with your doctor to go through.
Great. Next question. After a transplant, do the kidneys still cause pain?
That's a really good question. So depending where you are, where the transplant is done, and depending on your individual characteristics. So sometimes in some patients who have a lot of symptoms related to their kidneys, and this especially those with really, really big kidneys, they might actually remove the old kidneys. Now, this is not something that's typically done with transplants in general. Say you've got kidney disease for some other reason, they just leave the other ones in there, put in a transplanted kidney, off you go. But especially with those really, really big and complication type kidneys, they might actually do that. And if that's the case, then the kidneys would be out of there, and that wouldn't be the case. That's a very individual thing again, but it is becoming much more commonplace than it was, say, 10 years ago in those big symptomatic kidneys. The other part of that question sometimes people ask about is, well, is that going to happen in the new kidney? Is the new kidney going to start developing cysts and causing these issues? And the answer is no. This being a genetic disease, it's the genes in your own kidneys. That new kidney has its own gene. This will not happen in the new kidney.
Great. Thank you for elaborating on that. We have time for, I believe, 2 or 3 more questions. We have one here that's thanking you for all that you do. And they're wondering if enlargement of the kidneys due to PKD can cause bladder pain and impaired urine function, not UTI related.
Yeah, good question. That's where I always use my crude term I always use for people is real estate, right? There's only so much real estate in your abdomen. And the way I sometimes describe it to people that they kind of have a concept of is almost like when people are pregnant, right? Where although it's not causing an issue with the bladder function, if there's really big kidneys, it increases the pressure in your abdomen, and that bladder doesn't have as much room to expand. And I use that example, people are familiar with that. When you're pregnant, you have something sitting essentially pressing against the bladder, even though the bladder itself works totally normally, it just can't expand and you get those symptoms.
Understood. Thank you. How can we differentiate back pain if it's due to cysts or the backbone?
Yeah, that's a really good one. And that's why I mentioned it specifically with that one case, is because although that would be, so I showed that example of the person whose back, their spine alignment is thrown off because of their cysts. Although the cysts are contributing, that is a back pain type issue, and we kind of manage it as such. And that they can be really tough to tease apart. And that's where, again, a thorough evaluation and those imaging tests really helps, because just by the type of pain, it can be really hard to tease apart, especially if you have a big polycystic kidney that sits in a different place. most physicians will be used to a normal kidney kind of sitting right up under your rib cage, and they'll say, oh, well, if it's somewhere else, that's not from your kidney. But when you've got polycystic kidneys, all bets are off, because the kidney can kind of be essentially positioned anywhere in there. So just by how the pain feels, it can be really hard to tell. That's where you often do need those imaging tests. And yeah, your doctor to go through with it and try to tease that apart.
Good, thank you. Two last questions for you, Dr. Bevilacqua. Can you take an anti-inflammatory like Advil for a short time for other pain that's not related to PKD? And if so, for how long and how much?
Yeah, we get this question a lot as kidney specialists, not just PKD, but all kinds of kidney issues. So people are often very aware that those, so Advil, not specifically just Advil, anything that says anti-inflammatory on it, that's the term to look for. Those ones can be hard on the kidneys. Now, the problem is they also work, right? Compared to some of the other medications, and for some types of pain, they are quite effective. The real issue from the kidneys, a lot of times with those, is higher dose usage and specifically sustained usage of it. So that's where it really can become an issue. I'm kind of a realist, kind of living in the real world here, knowing that it works. High dose long-term usage is very different from occasional, just a small amount of it when something bad happens, kind of this once in a blue moon type of thing. So in that setting, I think that's okay, because again, you have to live your life. I always tell people that if you're looking for an over-the-counter medication, Tylenol is kind of your go-to because it doesn't have that effect. But then these anti-inflammatories, that's the one in the back pocket for when things are really bad. Just if you're using it occasionally, and if you are using them, they're much harder on you if you tend to be dehydrated. And when you're not feeling well, that tends to be when you're not drinking as much water. So if you are going to be using it, I'll also advise my patients, make sure you're making a specific effort to keep yourself hydrated.
Flush it out. Right. Excellent point. Whenever I have a virus, like a cold, my kidneys hurt. They ache. Is there a way to explain this?
Yeah, this often people notice this, when you get a flu or cold or something like that, you're feverish, everything kind of gets worse. So the way I kind of highlight things like that is it's probably unmasking what's already there. Meaning it's not like the cold or flu caused some damage to your kidneys. It's that you may have already had these sensations kind of flying under the radar, and then just everything hurts more when you're feeling unwell. You know what I mean? So it kind of brings it unmasks it, it brings it up to the surface. That's, I think, probably what's playing in there.
Right. And then with the last couple of minutes, Dr. Bevilacqua, I wonder if you could touch on, because it's a very topical point with respect to pain management, is the use of CBD and THC for pain management related specifically to PKD. Of course, with it being legal here in Canada for the last few years, more people are inclined to try a variety of those options to manage their pain. Could you speak from your standpoint on your thoughts and feelings and how maybe your patients navigate that part of pain management?
Yeah, absolutely. I'll first give another kind of shameless plug here that we do have that whole webinar. If you're interested, go through that on the BC Renal website. We actually have a long document to walk through this in a lot of detail, more than I can do it justice here in just a few seconds. But the short answer is, I'll always start with the point of saying, one, it's not been clearly proven in scientific studies for exactly this type of pain. I just always have to preface that. But again, I look at myself as kind of a pragmatist, a realist here. Some people definitely find benefit from it. And especially when we're talking about some of the other medications, my personal thoughts here are, compared to some of the other pain medications that can be used, that for a lot of people, this can be potentially even a safer way to go. So definitely one of the things that, I think it's very reasonable. I do encourage people to try, but if you're trying it, to do it in that kind of structured way. Again, you can go through in more detail in that detailed webinar, but the general points there are, if you're doing this is something that, one, your kidney team or your doctor should be aware of, just to make sure there's no problems with other medications. Make sure that when you're obtaining this, you're getting this from a reputable place. It's legal here in Canada, but there is still also a very large, what we call gray market. And, in terms of products that aren't really regulated, I say just steer clear of that. Now that we have the luxury of having very highly regulated products, that's the much safer way to go. And then the general rule of thumb there is what we say: start low and go slow, meaning that, the general tip we give people, if this is something you're thinking of, you want to try a little bit, see how it works. If it doesn't work, you can always add as time goes on, but rather than starting with a whole lot at once, and then you can run into trouble that way. So I do think it's a very reasonable thing to pursue. Just make sure we're doing it in a safe way, and that's really what all those resources we have are designed for.
Absolutely. And when we send out the recording, we'll of course provide any additional assets, including that presentation and the resources from your site as well, so people can dive into that long form if it interests them. Well, that's it, Dr. Bevilacqua. You're off the hook. I don't have any more presentation asks for you for the year. As always, you've been an absolute delight to partner with in this capacity, and I know I speak on behalf of those in attendance and the community at large that we really thank you for being a champion for the PKD patients across Canada and on a global level. So thank you for joining us today.
Oh, my pleasure. Always happy to be involved with the great work.
Amazing.
Thanks.
I wish you a great rest of the morning, and you can have your breakfast now.
Yeah. Thanks. Have a good rest.
Take good care.
Bye.
Bye-bye.